session, Dr. Kavita V. So she is a consultant at Shankar Eye Hospital, Shimoga, and also a beloved editor of the Karnataka State Journal. Ma'am, please join us on the stage. I would also like to call upon our panelists, Dr. Santosh Honawar. So please do come. He's our General Secretary AIOS and he needs no introduction. So please join us. And Dr. Rita BT, she is a glaucoma consultant at Aster RV Hospital, and I would also request you to please join us on the stage. And I'm Dr. Samhita, I'm the oculoplasty and squint consultant at Netradama Hospital, and I'll be the moderator for this session, and I'll take you through it. Thank you. So the first talk will be on acute SJS, Stevens-Johnson syndrome, a very important topic for us. It will be presented by Dr. Tanuja Gopal Pradeep, who is a consultant at Ramaya Medical Hospital and College and Hospital. Over to you, ma'am.
Thank you so much. Before I start, on this Guru Purnima day, I would want to give my salutations to all my teachers, especially from this institute, who have molded me, and they are the reason why I'm here. So, a happy Guru Purnima to all of you. So, my topic is Stevens-Johnson syndrome, acute stage management. All of us know what is Stevens-Johnson syndrome. It's an immune complex mediated hypersensitivity syndrome that typically involves the skin and the mucous membranes. So if it involves less than 10% of the body surface area, it's called SJS. If it involves more than 30%, it is called 10. And if it is in between, it is called overlap. Now, coming to the ocular manifestations, we'll not really look into the systemic manifestations because that's not what we are trained for. Ocular manifestations, all of us have to remember, they do not correlate with your systemic manifestations. You can have a severe 10 and no ocular manifestations, or you can have very severe ocular manifestations with no skin manifestations at all. Okay, very minimal skin manifestations. Ocular manifestations can vary from being very innocuous, it's a white bulbar conjunctiva, and only if you retract the lid, you'll see some small excoriation or some inflammation in the fornices, or like a severe red eye, or again a white eye, and only if you avert the lids, you will see that the palpable conjunctiva is denuded. Or it can be as severe as this, where everybody's scared to even go near this patient, and the conjunctiva is fully excoriated, cornea is excoriated, and it's very difficult to manage these kind of patients. Again, as I told you, it can be skin can be there might not be anything on the skin, but all the mucous membranes are denuded. What we have to know is management involves both systemic and ocular. We will not look into this systemic management, but systemic management is very important. We need to know that mortality is around 30 to 50% in the first year. And it's mostly a symptomatic treatment, very akin to extensive burns treatment, where airway, hemodynamic stability, fluid status, wound care, and pain management is their main importance for all the intensive care specialists. But for us, if we don't treat in the first week or we don't treat when the patient presents to us in the first acute stage, we might end up with patients like this who struggle throughout their life. This was a 3-year-old child. She came with acute Stevens-Johnson's. We tried to explain to the patients, the pediatricians, that we need to intervene with the amniotic membrane transplantation, but they didn't agree. They didn't give consent. And after 2 years later, she comes back with this, and it's very difficult to manage. And all of the cornea consultants here know, once you reach this stage, whatever you do, there's like, you're always trying to catch up. There's one more complication, and again you're trying to catch up with something else. And it's difficult to manage. So why we need to intervene in the acute stage? We don't want to end up with these corneas. And all of us know how difficult it is. It requires multiple procedures. And every time we under-promising. Whatever we do, we are not able to achieve what the patient is expecting. So coming to the ocular concerns in the acute stage, Stevens-Johnson's affects all the whole ocular surface. It affects the lid margins, so the meibomian glands are gone. So the lipid layer is affected. It affects the limbal stem cells. There's inflammation at the limbus, which can be very devastating. It affects the bulbar conjunctiva, so your goblet cells are gone. It affects your lacrimal gland drainage ducts. So all three layers of the tear film is affected along with the ocular surface damage. So acute stage management again is quite similar to chemical injury, but one good thing about Stevens-Johnson's is it's a one-time insult. It's not like a multiple insult like any other inflammatory disorders. So you need to manage inflammation and you need to manage the epithelial defects which are there, conjunctival or corneal. The inflammation part, yes, we have corticosteroids, cyclosporin to be started immediately with artificial tears. But the epithelial defect is what, if we ignore it, we say, okay, we'll only control the inflammation, let the redness come down, we have lost that crucial time where we can do something for the patient. So in our this one, amniotic membrane has been the most promising management, this one. So ocular management, obviously your books will say extensive lubrication, topical steroids, all that is important, but ointment application and glass rod is not, I mean, I wouldn't advise that. If you have extensive ocular surface damage, amniotic membrane transplantation should be the go-to treatment. There have been a lot of studies supporting ocular amniotic membrane transplantation which have shown improved visual recovery, but amniotic membrane has to be done within 5 to 10 days for improved visual outcome. Okay, so again, amniotic membrane transplantation, these patients is not just covering up an epithelial defect on the cornea, it has to cover from the lid margin, superior lid margin to the inferior lid margin with phonic sutures. So you cannot do a half-hearted amniotic membrane transplantation, it has to be completely covering the whole ocular surface. But the challenges in acute Stevens-Johnson syndrome is anesthesia. So general anesthesia, the anesthetist will not give you consent, the patient's relatives will not give you consent because it's usually children or it's severe cases that would require amniotic membrane transplantation. Acute stage is always a teamwork. Radiologists, intensivists, and ophthalmologists in the early stage is very important. It's not like, all should happen tandem. It should not be like, okay, we'll first save the life and then we'll call the ophthalmologist, which usually happens now. After everything is sorted out, they'll refer to the ophthalmologist after 1 month. By then, we've already lost the crucial time. So somebody like this, we wouldn't get any consent from the anesthetist or the pediatrician. What we did was, we didn't take him up to the OT. In the ICU, we just went, spread the amniotic membrane and put conformers there. So this is what happened. 1 week later, his skin also was healing along with his ocular surface was also not looking bad. At least we have prevented the symblepharon. I'm not saying I've prevented dry eye, I've not prevented any, any ocular surface damage. All that will be there, but this is manageable. Okay, this was another lady with 5 days, we did amniotic membrane, there's no symblepharon, so that is excluded. There is dry eye, there is excoriation of the lid, there is keratinization of the lid margins after 6 months, but it is again still manageable with contact lens, scleral contact lens. She is able to manage her, she's a teacher and she's able to manage her day-to-day activities. So again, this lady, we did a amniotic membrane transplantation and she doesn't even have dry eye. I'm not saying these are good results, but if we intervene early, ocular morbidity due to SJS and TEN is avoidable, and early recognition and appropriate treatment of ocular condition is a must in every case. Thank you.
Thank you so much, Dr. Tanuja. That was a wonderful presentation with very good clinical scenarios and very good outcomes too. Thank you so much. Any discussion, we'll keep it towards the end or sometime in between if we can, in view of many speakers and paucity of time. Next, I would like to invite Dr. Santosh Honawar. He is the keynote speaker for our session today and he needs no introduction. He's our Honorary General Secretary AIOS. He's completed his studies from Bangalore Medical College, post-graduation from AIIMS, and fellowships from the prestigious institutes of L.V. Prasad, Hyderabad, and Wills Eye Hospital, Philadelphia. He's a doyen in the field of oculoplasty and orbit, especially in ocular oncology, and has numerous publications, and most of the protocols what we follow has been set by him. So we are very happy to welcome you, sir, and he will be giving his talk on orbital cellulitis. Over to you, sir.
Thank you so much. Thanks for the invite. I'll be speaking on orbital cellulitis. Start off with this case. This young lady has unilateral proptosis. I will not tell you which eye. Sudden onset unilateral proptosis with ptosis with loss of vision. Just looking at this coronal scan, can you tell me which eye is abnormal possibly? Right or the left? Left eye is abnormal, you think? Why? Okay. Okay, what is the structure? Superior orbital vein, right? And what about the right side superior ophthalmic vein? Dilated. And I would say it is contrast enhanced, mucosa is enhancing, so right superior ophthalmic vein is dilated, but it is not filling with contrast. So what is the diagnosis? Keratoconus fistula, then the superior ophthalmic vein will be full of contrast. It is not enhancing, so it is cavernous sinus thrombosis, and that's her clinical picture. She started off with a boil on the nose and ended up with cavernous sinus thrombosis. That acute it is, but at the same time, one simple coronal CT scan can help you diagnose it. So orbital cellulitis or the manifestations of orbital cellulitis are very striking. They're staring at you begging for a diagnosis, and you have to identify those critical clinical signs. It's not that it is common, it is quite rare among all orbital manifestations. I'll be quickly dealing with bacterial and fungal. Now the sources of orbital cellulitis can be anything, right from the eyelid to the paranasal sinuses. All the surrounding structures of the orbit can be the sources. But if you look at the literature, predominantly it is the paranasal sinus. About 40% of orbital cellulitis arise from paranasal sinus infections. Endophthalmitis, orbital implants and dacryocystitis are rare causes. But in Asia, India, dacryocystitis remains one of the higher reason reason for orbital cellulitis that we have realized it contributes about 15 to 20%. Now the microbial profile varies with the age of the patient. Before HIV vaccine came about, Haemophilus influenzae was the most common isolate in orbital cellulitis in children. Now it is staph and streptococcus. In adults, it's generally polymicrobial and anaerobic, and MRSA has come in a big time. Now, grading of orbital cellulitis, we follow the Chandler's grading, although it is not sequential because most of the eyelid lesions such as stye, etc. cause preseptal cellulitis, and it may progress to orbital cellulitis. But if it is an ethmoidal sinusitis, it doesn't start with preseptal cellulitis, it will start with orbital cellulitis itself. So it does not follow the sequential situations that Chandler has described, but basically preseptal cellulitis is something that is not really dangerous. It's eyelid and periocular edema and erythema, where ocular examination is typically normal, there is no proptosis and there is no ocular motility restriction, not even pain on ocular motility. Typically this is caused by hordeolum, stye, etc. Whereas with these manifestations, if the patient starts developing ocular motility restriction or proptosis or painful ocular motility, especially towards the direction medial adduction, that means that ethmoidal sinus may be affected, then you think of orbital cellulitis. So the moment you start developing pain and ocular motility restriction or even very subtle diplopia in extreme positions of gaze, you suspect orbital cellulitis. Now subperiosteal abscess is an advancement, but it doesn't mean that orbital cellulitis progresses to subperiosteal abscess. It possibly is that if you are looking at an ethmoidal sinus pathology, there's a breakthrough and that can cause subperiosteal abscess as a first manifestation without going through the evolution of preseptal cellulitis, orbital cellulitis. Here the patient presents with very acute manifestation, decreased vision, papilledema, which could be compressive, motor and sensory signs which are disproportionate to inflammation. That means that the patient will not have much of inflammation, but will have very severe pain because of this subperiosteal abscess, which is acute. Now, orbital abscess presents with ophthalmoplegia, decreased vision, compressive or toxic optic neuropathy, and a palpable fluctuant mass. Obviously, this can arise from paranasal sinus manifestations or directly in the orbit. The last of it is cavernous sinus thrombosis, when the patient starts developing systemic signs, especially headache, nausea, vomiting, fever, altered consciousness, and patient starts developing bilateral signs or cranial nerve palsies, you should think of cavernous sinus thrombosis. There's a difference between child and an adult. In children, the manifestations are quite acute and severe, but complications are fewer. Drainage is hardly ever necessary. Children resolve with medical management, whereas adults, signs are and symptoms are very slow to progress, and generally adults need drainage. First step is CT scan with or without contrast depending on the systemic situation. Intravenous antibiotic therapy is the primary management, of course, and this is what is suggested. But what practically we follow in our center is empiric systemic antibiotic. Gentamicin and cefazolin combination is typically what we use, and if we are preferring oral antibiotics, it is amoxicillin and clavulanic acid. Every institute has their own antibiotic policy, and this is what is suggested. This is evidence-based suggestion on the intravenous and oral antibiotic therapy for orbital cellulitis, but it can be altered depending on the microbial profile in your own geographic location. Should a child with orbital cellulitis be treated with intravenous or oral antibiotics? There are about 400 studies, but none of which has shown conclusive evidence. But in a patient who has preseptal cellulitis or early manifestations of orbital cellulitis, a child, we would prefer oral antibiotics. But if it is full-blown orbital cellulitis, hospitalization and intravenous antibiotics are necessary. Now, what about systemic steroids? Intravenous betamethasone or oral corticosteroids are mandatory when the patient reaches the resolution phase of orbital cellulitis. That means that after having started antibiotics, we should wait for about 72 hours before we start intravenous steroids or oral steroids. It provides faster resolution and minimizes functional deficit, that's for sure. And also, if a patient has optic neuropathy, then oral steroids or intravenous steroids can be started a little early. Surgery is performed in non-responding orbital abscess, non-responding sinus infection to decompress the optic nerve and also to obtain material for culture sensitivity. In a situation that the patient is not responding to standard antibiotic therapy, poor response, then you want to know what is the sensitivity, and if it is not an accessible infection, that means that the orbital abscess is deep down or you cannot do a sinus surgery, then you can even go with a needle, ultrasound guided or CT guided, and get a material for culture sensitivity. Surgery is less often required in children. So as I mentioned, surgery could be image guided aspiration with a large bore needle, orbital approach drainage, or endonasal approach if there is frank orbital paranasal sinusitis. Complications, you can note here that about 30% end up with visual loss. Currently with the suggested protocol, it is less than 10%. Early initiation of steroids and multiple antibiotics as a protocol that you start off. Functional deficit in terms of ocular motility restriction, etc. is about 12 to 20%, and mortality is 3%. Coming to mucormycosis. We understood a lot about mucormycosis in the last 3 or 4 years, unfortunately, because of its association with COVID. Otherwise, it used to be a very rare manifestation. I had probably seen about a dozen of them early, but in just 3 years, last 3 years associated with COVID, we saw hundreds of them. And we understood a lot about mucormycosis. It's an acute fulminant orbital infection caused by Rhizopus, mucor, or Absidia. Rhizopus oryzae is the most common organism. Usually manifests in immunocompromised individuals, very abrupt onset, rapid progression, vascular occlusion resulting in patient manifesting with PL negative status, manifested by tissue necrosis. These are some of the risk factors that are known to be associated with mucormycosis. We are aware of this, but what is important is that we should recognize early masquerades. It may present with ocular motility restriction as the primary manifestation. Patient presents with ptosis and diplopia. That is all the patient has. And some pain. So what do you think? You think that it could be, say, Tolozan syndrome, superior orbital fissure syndrome, or cavernous sinus syndrome is what you think initially, but within the next 24 hours, by the time the patient comes back to the MRI, he would have progressed very remarkably. So you should never miss mucormycosis, even if it presents with any of these masquerading situations, inflammatory, neoplastic, vascular, or neuroophthalmic. This was a set of cases that we published, and this was very early in the course of COVID that we put together cases from Mumbai and Hyderabad and published just a small bunch. Within the next few months, couple of months, that was in January 2021, we had fire. Now, the hundreds of cases, we are inundated with 12,000 cases of mucormycosis in India from March 2021 onwards for about 3 or 4 months. So we had an opportunity to study these stage-based management approach with real-world data. This was a OPI IGO collaborative study. It involved 2,826 cases, which was very difficult to collect during that phase because everybody who was involved in COVID management or RMS management was involved in patient care and they had not enough time to provide data. But despite that, we had very good data. And we found that the primary symptoms of mucormycosis was orbital and facial pain and orbital and facial edema. So if a patient were to have orbital and facial pain of acute onset in a situation which are the predisposing factors, say uncontrolled diabetes, immunocompromised patient with leukemia, then you could suspect mucormycosis. Primary signs mirror primary symptoms, periocular facial edema, and loss of vision. Loss of vision is one of the most important signs of mucormycosis. For diagnosis, you cannot simply do a nasal swab. You should do a targeted nasal swab. That means that you should do endoscopy, which all the oculoplasty surgeons are familiar with. You should do endoscopy and get the swab from the target area, which could be a black eschar or an area where there is drainage of purulent material. Otherwise, if it is just a swab, random swab done blindly, then you have a very low yield of 30%. Now you can do what is called microbiopsy. Microbiopsy, it's a very simple process where you insert an endoscope and use a spatula or a curette or even an evisceration spoon and get material, scrape the material off the mucosa at the edge of the eschar and hyperemic mucosa. That is where you would get the highest positivity rate of which is about 75%. So just by using an endoscope and doing a microbiopsy, your diagnostic yield is going to be very high, 75%. And you should insist on the microbiologist to do an immediate KOH calcified white stain immediate. That will give you diagnosis within 15 minutes stat. You don't have to wait for culture, which takes time. Histopathology also takes time. If you have any doubt at all that microbiology is negative, but it might be within the tissues, then you can ask your pathologist to do even frozen section or squash and imprint cytology. CT scan lags behind in terms of the diagnosis, radiological diagnosis. It's the MRI signs that are the first. CT scan will diagnose probably, say 6 hours or 12 hours after the MRI signs manifest. The first MRI sign in a paranasal sinus involvement is called the black turbinate sign, if it is done with contrast. That means that in a contrast MRI, if ipsilateral turbinate does not enhance at all, that means that the patient has ischemic manifestations of paranasal sinus infection, most important cause for which is mucormycosis. So this is the first sign that you see. And here you can also note that the infraorbital nerve is already involved. The patient has paresthesia in the cheek area already. So MRI is also important to know and stage the disease because these are the signs that manifest even before the clinical signs manifest. Now staging is based on anatomical progression, so we came up with a staging system. Stage 1 is involvement of the nasal mucosa, which is diagnosed only by looking at the nasal mucosa using an endoscope. So endoscope is a real big boon in the diagnosis of mucormycosis in an early situation. ENT surgeons are not required to do endoscopy. We do it ourselves and we can recognize most of these signs. Second stage is involvement of the paranasal sinuses, where of course radiology comes into the picture. You can't see through the paranasal sinuses. Endoscope doesn't get in, so you look at the MRI or CT scan. Now if only one paranasal sinus is involved, it is called 2A. If two are involved, then it is 2B. 2C is when the palate or the contiguous structures get involved, and 2D is bilateral paranasal sinus involvement. Stage 3 is involvement of the orbit, at which stage most of the ophthalmic or oculoplastic surgeons come into the picture. In stage 3, you have localized orbital involvement or two structure involvement, which is 2B, 3B. 3C is superior orbital fissure or orbital apex involvement when the patient comes with ocular motility restriction and sudden onset ptosis. And stage 3C also involves vaso-occlusive central retinal artery or ophthalmic artery occlusion, diffuse orbital invasion, and bilateral orbital disease is 3D, and 4 onwards is intracranial extension. Now what is the management? Management triage is very important. Whenever you have a probable or proven ROCM, you start these patients on amphotericin B. Liposomal preferred, but amphotericin B is mandatory. And once you start the patient on amphotericin B, you can wait between 24 to 72 hours. If the patient is improving, that's great. If the patient is rapidly progressing, even within 24 hours, you can go to the next stage, which is paranasal sinus debridement. And if the patient has orbital component which is limited, you can do TRAM, that is orbital injection of amphotericin B. If the orbital component progresses, then you should go in for orbital exentration. There are patients where you can avoid orbital exentration. Patient like this definitely need orbital exentration. But a patient of this sort where there is posterior orbital extension, we could do a TRAM and avoid orbital exentration. So in our study, out of about 3,000 patients, we had 22% mortality, which is very high, but these had comorbidities with COVID as well. The masquerades include patients with leukemia can present with preseptal cellulitis. This patient of T-cell lymphoma can look like orbital cellulitis. This was a patient with DLBCL who had looked like has facial edema and orbital cellulitis, responded to chemotherapy. Child with retinoblastoma with sterile orbital inflammation. Again, a child with retinoblastoma with tumor necrosis with sterile orbital inflammation. These are not to be missed at all. So in conclusion, I would say that orbital cellulitis has a very large spectrum. Of course, bacterial and fungal predominate. Complications can be life-threatening. The early signs are actually staring at you, begging for a diagnosis, as I said. Endoscopy has a big role in the diagnosis, early diagnosis of ROCM. Thank you so much.
Thank you so much. Can give up-to-date info about the thing. I would like to tell that during the time of mucormycosis, sir was mycosis cases, and it was compiled from
A very good morning to everyone. Before we begin, I would like to thank Dr. Anuradha and the entire BOS committee for giving me this opportunity to present here. My topic for today is acute angle closure glaucoma. Just a brief insight into the disease process before we head on to the management proper. As we are all well aware, the aqueous humor secreted by the ciliary body circulates from the posterior chamber through the pupillary aperture into the anterior chamber and then drains out through the trabecular meshwork. Now, what happens in an acute angle closure attack is this pupillary block in the mid-dilated state because of the increased opposition between the posterior surface of the iris and anterior surface of the lens, resulting in aqueous humor accumulating in the posterior chamber. This increased fluid pressure pushes the peripheral iris forward, which abuts against the cornea and blocks the trabecular meshwork, leading to raised intraocular pressure. There are several risk factors, but the major predisposing risk factor is the variation in structural anatomy of the eye, which includes shorter axial length of the globe, small corneal diameter, anterior position of the lens with respect to ciliary body, increased thickness of the lens. Demographic factors, we're all well aware, it's more common in female patients in the age group of 6th to 7th decade and in Asian populations. There are certain drugs such as topical mydriatics, anti-Parkinsonian drugs, antihistamines, among others to name, which have the potential to induce an acute angle closure attack. Acute angle closure attack patient usually present with significant and distressing symptoms. The ocular symptoms include unilateral, intense periocular pain, redness in the eye, blurred vision, and multicolored halos around the line sources. General symptoms in the form of nausea, headache, and vomiting can be severe. Coming to examination, we notice that there's a decreased visual acuity. Slit lamp examination reveals perilimbal hyperemia in the form of a ciliary flush. There's corneal edema or haze, and anterior chamber is shallow both centrally as well as peripherally. IOP can be high as to the extent of about 50 to 80 millimeter of mercury. If the corneal haze is not much and gonio can be performed, in the affected eye it reveals a closed angle. If not, a gonio performed in the fellow eye will always show a narrow angle with a shallow anterior chamber, and also mild to moderate AC reaction will be seen. This is here a UBM picture which shows again the peripheral iris pushed forward in case of an acute angle closure attack. According to the recent studies, an acute attack of PACG is defined by the presence of at least 2 symptoms, such as ocular pain and nausea or vomiting, IOP more than 21 millimeter of mercury, and at least 3 findings on clinical examination, such as corneal edema, shallow anterior chamber, gonioscopic confirmation of angle closure, etc. Now, we've established a diagnosis of PACG, so what next? A patient with PACG with pupillary block, treatment can be divided into 3 stages. The immediate medical therapy, it's basically to break the attack, relieve the acute symptoms by lowering the IOP, which not only aids in the further diagnosis and treatment, but also prevents the pressure-induced damage to the trabecular meshwork as well as the optic nerve. This is followed by definitive intervention in the form of laser iridotomy, not only of the affected eye, but also the fellow eye. The fellow eye has a propensity of 40 to 80% chance of developing an acute angle closure attack in the next 5 to 10 years. Hence, it's imperative to perform laser iridotomy in both the affected as well as the fellow eye. And this should again be followed up with long-term glaucoma surveillance and IOP management of both the eyes. Coming to medical management, ask the patient to lie down supine and start with systemic IOP lowering medications such as carbonic anhydrase inhibitors, which includes acetazolamide, which can be administered orally or IV in a dose of 500 mg stat, followed by 125 to 250 mg Q6 hourly. The next group of drugs include systemic hypoosmotic agents. These are considered the most effective means of lowering an IOP in case of an acute attack of PACG. These include oral glycerol in the dose of 1 to 1.5 kg, which is contraindicated in diabetics, wherein you can use oral isosorbide. Normally, IV mannitol 20% is given in a dose of 1 to 2 grams per kg over 30 to 45 minutes. Onset of action starts in about 30, peaks in an hour, and lasts for about 6 hours. Coming to topical medications, beta adrenergic blockers in the form of timolol or livermolol 0.5%, 1 drop stat is the dose. We basically reduce aqueous humor formation, thereby reducing the IOP. Alpha adrenergic agonists such as apraclonidine or brimonidine, again 1 drop stat. These basically reduce the aqueous humor formation and also enhance uveoscleral outflow, thereby reducing the IOP rapidly. They're also used prophylactically to prevent the IOP spike post-laser iridotomy. Topical steroids in the form of prednisolone acetate 1% eye drops are used 1 drop hourly initially to control the inflammation, which can later be reduced to Q6H depending upon the condition. This is basically to reduce the anterior chamber inflammation and prevent both anterior and posterior synechiae formation. Prostaglandin analogs are generally contraindicated because of the propensity to exacerbate uveitis. Miotics, normally it was widely used by default in case of an acute angle closure attack, but in case of an acute angle closure attack, the IOP is so high that the pupillary muscle, sphincter muscle is ischemic, and hence they're unresponsive to topical miotics. So once the IOP is brought down below 40 millimeter of mercury, then topical miotics in the form of pilocarpine 1 to 2% can be used as 1 drop, 2 doses, 15 minutes apart. They basically help to improve the ability to perform iridotomy. Along with this, we need to administer antiemetics and analgesics to provide patient comfort. There are certain slit lamp maneuvers which have been advocated to mechanically reduce the pressure. This includes axially depressing the cornea using a small gonio prism that's a size 4 mirror, or using a blunt instrument in the form of moist cotton bud. They basically, axial force indenting the cornea pushes the central aqueous towards the periphery, momentarily forcing open the angle, thereby reducing the IOP. Anterior chamber paracentesis is performed under topical anesthesia. We here use a small 30 gauge needle and slow penetration of the anterior chamber, always under the direct visualization of the slit lamp should be performed. This can reduce IOP to the extent of about 10 millimeter of mercury, which helps us to clear the cornea for further definitive interventions and also to achieve meiosis. Coming to laser interventions in the form of peripheral iridotomy using argon or Nd:YAG laser. This basically overcomes the pupillary block and establishes a free communication between the anterior and posterior chamber, and as such there's an insufficient pressure differential to push the iris forward. An ideal iridotomy should be between 150 to 200 microns. Peripheral iridoplasty, this is usually indicated in acute PACG, which is unresponsive to medical treatment, or when there's laser iridotomy is precluded by extensive anterior chamber shallowing, corneal edema, or inflammation. Here basically we're using argon laser to flatten the peripheral iris and have it retract centripetally towards the pupil away from the trabecular meshwork. Surgical iridotomy is very rarely used nowadays. It's indicated in case of laser fails to produce a patent iridotomy or not available, opacities of the cornea interfere with the treatment, or patient is uncooperative or unable to sit the slit lamp. Now, if the medical management and the laser iridotomy fails to control the IOP and the optic nerve damage has already been documented, then we need to consider the surgical options, which include lens extraction with or without goniosynechial lysis, filtering surgery alone, combined lens extraction with trabeculectomy, goniosynechial lysis. Thank you. Yes, sir.
Thank you, Dr. Rita. That was a great talk about the acute angular closure glaucoma. Our next speaker is Dr. Ranjita. She is assistant professor at Minto Eye Hospital, Bangalore. And let's hear from her about the challenges in corneal tear management.
Good morning, everybody. I'll be talking about the corneal tear management in these following headings. How to approach a patient of a corneal tear. ideally, you had to identify what are the life-threatening injuries and then treat them first and then go for ophthalmic intervention. All these cases generally are medico-legal aspects. You have to enter them in the medico-legal registry and ask for any history of medical problems and any previous ocular surgeries and the visual acuity. A patient should be evaluated in structural examination part to palpate the orbital margins, and functional evaluation has to be done in terms of visual acuity, pinhole visual examination, and pupillary reaction has to be noted. A detailed slit lamp examination has to be done to know the extent of the corneal injury, whether any scleral injury is there or not. And CTL test has to be done to look in case of occult corneal injury patients. This is one case where there was a embedded of the plastic foreign body at the level of the limbus along with the corneal tear. Generally, investigations like X-ray, CT scan, MRI scan, anterior segment OCT, B scan, ultrasound generally done to look for any location of the foreign body and number of the foreign bodies. How to counsel a patient of corneal tear? First and foremost is you tell what is the aim of the surgery, that is the primary aim of the surgery. Following that, whether the patient requires multiple surgeries or not, what is the visual potential and complication associated with. In case if the injury is very severe, there may be need for enucleation. Consent has to be taken for that also. How to handle a patient of corneal laceration? Look for whether there is a partial laceration or the full thickness laceration. If there is a partial laceration, whether it is undisplaced or displaced. If it is undisplaced, it can be bandage contact lens and tissue adhesive, and patching can be done. If it is a displaced flap, always better to do a suturing. If it is a full thick, definitely suturing is compulsory. How to prepare a patient before taking for surgery? Apply a protective shield, avoid topical medication because they can penetrate and can cause macular ischemia. Tetanus prophylaxis has to be given, and the NPO status if you are taking patient for general anesthesia. What are the main goals in the management of the tear? First and foremost is restoration of the globe. We are not worried about the visual potential. Next is avoiding further injury or any complication associated. Then coming to the corneoscleral perforation. If there is no tissue prolapse, clean the wound and then suture. If there is iris prolapse, look for the viability of the iris and you can reposit back. If it is a non-viable, contaminated, then excise the iris and then do the corneal tear repair. If the choroid and retina is a prolapse, reposit back. If there is a vitreous prolapse, do the vitrectomy with better to do with cutter. What are the steps? Universal speculum has to be placed very slowly so that no intraocular content should come out. Copious irrigation has to be done to take out all the contaminants, and a side port incision has to be done, and wash can be done, and viscoelastic is injected to make the anterior chamber deeper. First, start the suturing from the periphery. If you are taking a peripheral suture, it has to be longer and a larger bite has taken so that it flattens the periphery and steepens the central so that the vision will be better in the post-operative period. So there are some principles, or we can call it as a mantras before taking any patient for corneal tear. The ideal wound should always be watertight, and there should be minimal scarring post-surgery. In the center, if you are suturing, we need to take short and smaller bites so that later corneal scarring will be less and astigmatism will be less. If you're doing in the periphery, it has to be always a larger bites. The depth is 80 to 90% depth, corneal depth is taken. It has to be equal depth and equidistance on both the sides. What are the correct and incorrect closure methods? It has to be 90% depth and equidistant both the side. If there is a shallow thing, it can cause internal wound gaping. If it is unequal distance, it can cause wound override. And if it is more than 90%, then it can cause microbial contamination and chances of endophthalmitis is more. for laceration affecting the visual axis, central should be always avoided and peripheral should be larger by size, I already told. In stellate perforation, there's Easton's method is used. How to manage post-operatively? Subconjunctival antibiotic injection is given. If it is more than 72 hours of any corneal tear, you have to give intravitreal antibiotics. And 4 days of IV antibiotics and topical antibiotic drops of vancomycin and ceftazidime is advised. This is one case where there was a history of nail trauma injury and the patient had iris prolapse and it was sutured. A large peripheral longer bites was taken and this is the end of, at the end of 1 week. This is a history of a schoolgirl, 11-year-old girl was injured with the scissor. There were 2 wounds. The 2 wounds were sutured. This is a very challenging case where right eye the patient is having hydrops and the corneal scarring. When the left eye patient is having keratoconus with a minimal trivial trauma, patient had iris tear. So larger peripheral bites were taken. Again, one more trauma with the stone. And when to remove the sutures? Usually at the end of the 3rd month, we generally remove the suture. In a children, we'll remove at the earliest possible. The prognostic factors in case of corneal tear, good prognosis is expected if the patient is having a good visual acuity at the time of presentation and any absence of hyphema, iris and lens and vitreous involvement. Poor prognosis if there is a vision is less than hand movements and longer perforation more than 4 mm and delayed repair more than 36 hours. Thank you.
Thank you so much, Dr. Ranjita. That was a wonderful talk. And as you clearly showed, the limbal tears are the one which are more difficult to handle. I call upon our next speaker, our chairperson, Dr. Kavita, to give her talk on pediatric traumatic cataract. So let's hear from her.
At the outset, I would like to thank BOSS for this opportunity. I have no financial interest in this presentation. No, as we know, there are 2 types of, you can categorize trauma into penetrating and blunt trauma. So as my previous speaker has spoken about corneal and corneal scleral tears and the various tears associated with cataract, now I'll talk about the way to tackle the cataract. So because of trauma, there can be dislocation of the lens, either anteriorly or posteriorly. So the posteriorly, it is tackled by the vitreoretinal surgeon. Anteriorly, of course, we need to tackle it at the earliest, probably along with the corneal tear repair. So the cataract, it can be intervened in the first sitting or at the second sitting. Blunt trauma, usually the cataract develops a bit late or early if the capsule is ruptured. Please remember that in children, all procedures, including examination, may need sedation or general anesthesia, even for the preliminary examination. So now let us look at various scenarios. If the anterior capsule is breached, what do? Intervene in primary sitting. If there is posterior synechia or anterior synechia, release it at the same. And rhexis, you try to do it in the remaining part of the capsule, or you can convert it into can opener technique. I prefer to do the dry aspiration of cortex because we do not know exactly what is the status of the posterior capsule. In case the anterior capsule is intact, then go ahead and do a continuous capsulorhexis and cortical aspiration as in regular case. But always remember, we do not know the status of posterior capsule until we see it. So why do we want to intervene at the earliest is to prevent secondary glaucoma, because the capsule is breached and the cortex is, it is obstructing at the angle and causing raised pressure. And there is definitely post-tear inflammation. Now, in case the posterior capsule is breached, what to do? If it is a small PCR, do anterior vitrectomy, convert the small opening into a regular opening as much as possible to a size of 5 mm. That's what we aim at. And if there's a large PCR, do anterior vitrectomy and plan for secondary IOL implantation. In case the posterior capsule is intact, then go ahead doing a manual or vitrector, using vitrector posterior capsulotomy about 5 mm size. And anterior vitrectomy I do in all children if the child is less than 8 years. What is important in IOL power calculation and IOL implantation is look at the tear where it is and how much is the scar size, whether it is large and central. So in this, what to do for the IOL power calculation, I consider the K reading and A scan of the other eye. And in B scan when we are doing, usually we do not do in the primary when the patient comes over. Usually after the repair, you can take up the child for B scan. If possible, you look for PCR. It is possible to understand there are some vitreous echoes just behind the lens capsule, posterior capsule. Also, you can consider the axial length in B scan. Now, coming to placement of IOL, it basically depends on the visibility of structures behind the cornea, and of course the status of anterior capsule and posterior capsule. Now, let us look at various scenarios. If AC and PC are intact, I prefer foldable acrylic IOL in the bag. If AC is intact and small PCR, then foldable IOL can be very well placed. If AC is intact and there's a large PCR, I prefer 13 mm IOL, either single piece or 3 piece, and it is usually in sulcus. And if his AC is ruptured and PC is intact, then I would go ahead with same 13 mm single piece or 3 piece IOL, and it's invariably in sulcus. If both are ruptured and it's a large PCR, I prefer secondary iris claw lens, or anybody doing SFIL can go ahead with that. What is important is also to measure the size of the corneal diameter so that you can understand what should be the size of the IOL. And to improve visibility during the surgery, you can use viscoelastic frequently over the cornea. There are some scenarios here. You have an irregular pupil and the capsule is ruptured very badly. I stain with blue just to understand how much of capsule is left behind. I prefer dry aspiration of cortex. This is the 23 gauge cannula that I use. I aspirate the superior or subincisional cortex through the side ports. There's a large PCR which I have noticed. So I prefer, definitely I prefer the dry. It does take little time. I do a thorough vitrectomy. This is a large PCR, so I go in for SFIOL, and a PI is a must. This is a secondary intervention. Tear is already repaired. I stain with blue. Dry aspiration again. What I notice is the fish mouthing of the anterior capsule. Since the posterior capsule is intact, I placed I just enlarged the anterior capsule using the Utrata forceps. I placed a three-piece IOL in the bag. This is another scenario where there's anterior synechia as well as posterior synechia post-tear repair. Release the anterior synechia using the Vannis scissors and the posterior synechia using the dialer as well as the iris repositor. I managed to do a small anterior excess, but in this case the posterior capsule was very thin, but I went ahead and placed the single piece rigid IOL in the sulcus. What is essential is to understand how long these IOLs will be well centered over a period of time in children especially. So I prefer a larger lenses. 3 pieces preferred, but single pieces also have given long-term good results. So I'm placing it in the sulcus for better stability. So in secondary IOL implantation where there is inadequate capsular support, the lens of choice is the iris claw lens as regards to me. I am checking the claws here before really implanting it. It is very essential because once you go behind the iris and then you want to tuck it, the claw may not open to enclave the iris tissue. Through the side port, I just enclave the first haptic, go behind, and then enclave the other. A PI is a must in all these situations to prevent secondary glaucoma. To wind up our own 10-year retrospective study, we found that 43% had good visual acuity between 6.6 and 6.12. A good surgical and good visual outcome is obtained if managed well at the right time with the right technique. And all patients have to be followed for uveitis, PCO, secondary glaucoma, corneal decompensation, and retinal complications, and of course the IOL status. Thank you.
Thank you so much, ma'am, for those beautiful videos and a wonderful presentation. I invite our next speaker, Dr. Karthik Mehta, who is Senior Retina Consultant at Karthik Netralaya, Bangalore. And he'll talk about a condition which causes much pain to the patient as well as the ophthalmologist. Let's hear from him about central retinal artery occlusion.
Good afternoon, everyone. Good morning, everyone. And I thank boss for this opportunity. So I'll be sharing a few slides on central retinal artery occlusion, which is actually speaking one of the acute emergencies in ophthalmology and in retina. So all of us know the central artery is the branch of the ophthalmic artery. It has no collaterals. There have been innumerable studies on the how long the retinal tissue can tolerate hypoxia. So it is said that within about 100 minutes, if the hypoxia is reversed, then the retina reperfuses and starts functioning appropriately. And still there will be some amount of function regain or visual regain if the hypoxia is reversed even in about 4 to 6 hours as well. So majority of the times when I see a CRO in my clinic, it is delayed. It's either delayed because the patient is unaware that he has to make an urgent visit to the hospital, or it is delayed because the staff are not tuned to recognizing this condition and allotting them a closer or a more earlier appointment. So I think it is very important for us to spread the message both to the patients and to our staff and train them to triage emergencies and identify these conditions at the earliest, because time is very crucial in these conditions. It is very similar to a stroke management where there is a golden window. I think here also there is a golden period which we all have to respect. Now, usually the presentation is in the elderly age group. They present with sudden onset of painless, profound loss of vision. They may have a history of transient blurring of vision in the past, and many of them have comorbidities like diabetes, hypertension. I think a CRO is a spotter. All of us would have seen a case, or at least PGs would have seen photos of CRO, characterized by the cherry red spot caused by the choroidal perfusion supplying the fovea, whereas the edema causing the opacity of the macular region. The vision is never NPL. If it is no perception of light, then it is ophthalmic artery occlusion complicated by CRO. It cannot be independent CRO. There is never NVI at presentation. So if you're seeing NVI at presentation in a patient with CRO, then it is again the patient has ophthalmic artery occlusion, which has caused the NVI formation, and he's progressed to develop a CRO over course of time. Emboli may be seen in about 20% of the population, but what is interesting is if an emboli is noted, then they have a higher risk of mortality as compared to patients where the emboli is not seen. If the CRO is chronic, then there is optic pallor, optic disc pallor, arteriolar attenuation, and macular thickening. There could be other findings as well, like the cilioretinal sparing, which is seen in about 10% of patients, where the macula still remains perfused because of the serioretinal artery, which is a low perfusion circuit. There may be pallid. If you see pallid disc edema with CRO, if there is disc edema with CRO, then we term it as arthritic CRO, and this is a systemic emergency caused by giant cell arthritis. So these patients need immediate workup for CRP, ESR, and immediate referral to an intensivist. There can be combination with CRVOs and CROs. Investigations, clinical examination is more than enough to identify a CRO. You don't need to really investigate it ocular-wise. But there has been OCT tests which have been, which tells us the intensity of the CRO. So when there is non-perfusion or hypoperfusion, what gets usually affected is the middle layers of the macula, as shown in this. I have a pointer. Okay. So what gets usually affected is the middle layers. Then it is the inner rail hyperreflectivity or opacity, and then there is thickening of the inner retinal layers. FFA is hardly needed. It may be needed when we want to differentiate whether it's a pure CRAO versus an ophthalmic artery occlusion with a CRAO. Systemic workup, we are all aware of it. Usually we recommend a carotid Doppler. We do recommend a 2D echocardiogram. We do recommend an ECG. But when CRAOs are happening in young people, we have to look at coagulation profile disorders, in which there are a lot of tests which are depicted in this slide. How do we treat? All of us are aware of gonio massage. We use a 4-mirror lens. But if you don't have a 4-mirror lens, you can also do it with the thumb finger pressing on the sclera while you are examining with a 90D lens. What you're trying to achieve is basically press or depress on the sclera till you have pulsation of the central retinal artery. Hold it for 5 seconds and then release it. So you're trying to pump the circulation, cause little ischemia, hypoxia, causing vasodilation, and allow the embolus to move to a peripheral zone, and that way reducing the or improving the perfusion. Usually you could do this for about 10 minutes, and if it fails, then I think I switch over to doing a paracentesis and reduce the pressure immediately so as to cause vasodilation and encourage the embolus to move peripherally. There have been a lot of other therapies which have been advocated, but I don't think there is any particular way which says that this has to be done. Hyperbaric oxygen is postulated. What they are doing is intra-arterial thrombolysis. So the central retinal artery is cannulated and TPA is injected so as to increase the, reperfuse the retina. AC paracentesis can be done, and this is a technique. You have to start from either the 3 or the 9 o'clock and try to go towards superior or inferior, thereby preventing damage to the inadvertent damage to the lens. So in conclusion, it is the only true acute retinal emergency. I think earlier we pick it up, the better the chance of us trying to save vision. And systemic investigations are very important because it becomes life-saving at these times. Interestingly, there are reports of iatrogenic CRAO. Something as simple as a parabulbar block can precipitate a CRAO by causing spasm of the central retinal artery. So there has been a publication recently with a large series of cataract patients who developed CRAO. So I think this is something that we have to keep in our mind when we are doing other procedures as well. Thank you so much.
Thank you, Dr. Karthik, for that crisp presentation, and thank you for using the assets, allocate and act, taglines, which is actually the theme for our today's session. It was a wonderful talk. Thank you. I invite our next speaker, Dr. Preeti Sridharan. She's a retina consultant at Netradama Hospital, and she will be talking to us about post-operative endophthalmitis.
Thank you, BOS and Dr. Samita, for this opportunity. So, post-operative endophthalmitis is an emergency that we can see after any intraocular procedure like cataract surgeries, glaucoma surgeries, retina surgeries, cornea surgeries, intravitreal injections, and secondary IOL. So we'll be dealing with this in 3 parts, that's diagnosis, management, and prevention. So when we see a patient like this in the post-operative period, neither the doctor nor the patient is happy. But depending on how they present and when they present, we need to diagnose these cases. Any exaggerated post-operative inflammation on day 1 or day 2 is most likely to be a TAS. But endophthalmitis caused by a very virulent organism, a very fulminant endophthalmitis, can also present with such signs on the first post-operative day. And surgical trauma by a prolonged surgery or complicated surgery can also cause such intense inflammation. Most often, endophthalmitis is seen between day 2 and 14, especially between day 3 and 7. In the same period, retained lens matter or a flare-up of previous uveitis can also be seen. After about 14 days, any inflammation that we see is likely to be an endophthalmitis or could be a flare-up of previous uveitis. On day 1, it's important to differentiate between TAS and ENDOPH. I think you must have heard of various talks on TAS in this conference itself. Limbus to limbus